is Tanna. I will speak about the initial manifestation of cerebrovascular accident. So, firstly, epidemiology and the risk factors. There are approximately 7,95,000 new and recurrent strokes annually in the United States, which is the in which like 6,10,000 being in the first events and 1,85,000 being the recurrent events. Some 88% of these strokes are ischemic and 80% to 12% of the ischemic stroke result in the death within the 30 days. On the average, there are every 40 seconds, someone in the United States has a stroke. Despite of gradual declines in the overall stroke death rates in many industrial countries, stroke remains the leading cause of the death, disability, and the United States and worldwide. Stroke mortality is particularly high in Eastern Europe and in Asia. It is recorded by World Health Organization in 2004. By 2020, 19 of 25 million annual stroke deaths will be in the developing countries. So as you can see, the risk factors for the ischemic stroke, there is age, gender, race, ethnicity, family history, genetics, the person with arterial hypertension, ischemic attacks, stroke, and the cardiac diseases. Cigarette smoking, alcohol consumption also may be the risk factors. So obesity. Then we'll talk about the pathophysiology of the cerebral stroke. So, firstly, there may be many causes. First, there may be small artery occlusion, large artery atherosclerosis, cardio-aortic embolism, or the other factors which can lead to cerebral stroke, which firstly decreases the CPF, which terms which affects us. There is reducing reducing the level of oxygen and glucose in the infract location, which increases the anaerobic metabolism, which in return reduces the formation of ATP and increases lactate. Increasing the lactate leads to inflammation, and decrease in ATP may lead to secondary inflammation or to the necrosis by this mechanism also. Also, the main cause may be to increase in the glucose metabolism in penumbra, which leads to increase in the volume of infarct. So this is the whole pathophysiology of the cerebral stroke. Then the clinical syndromes of the cerebral stroke. The clinical symptoms, firstly, the transient ischemic attacks. The TIA is the temporary or the non-marching neurological defect of the sudden onset attributed to the focal ischemia of the brain, retina, and the cochlea, and lasting less than 24 hours. Yet more TIA last only for the few minutes. Episodes that last longer than 1 hour are usually due to small infractions with advent diffusion weight magnetic resonance imaging (DWMRI) sequences. The time-based definition of TIA is inadequate because of the infarction are frequently evident to the on DWMRI the patient whose clinical manifestation resolved completely within few hours. Thus, a tissue-based modification of the TIA definition has been proposed, suggesting that any transient episode, regardless of the duration, associated with the clinical appropriate lesion by MRI is defined as a stroke, and that otherwise prolonged events more than 1 to 6 hours in the duration defined as a stroke rather than TI when otherwise clinical appropriate. So other syndromes may be carotid artery syndrome. You can see the CT scan for the carotid artery syndrome shows the patient of the 63-year-old man with left-sided weakness and alveolar demonstrate right anterior cerebral artery ACA territory infarction. You can see in the CT scan. So ameurasis figures may be described as a sudden onset of transient monocular visual loss, the curtain or the shadow pattern with the loss of vision moving superiorly to the inferiorly is described only in 15% to 20% of the patient. Less commonly, concentric vision loss presumed to be caused by diminished blood flow to the retina is described. Most attacks are spontaneous and unrelated to the positional changes. The vision loss is often brief and painless. The duration of vision loss is usually 1 to 5 minutes and rarely lasts more than 30 minutes. After an episode of amaurosis fugax, the vision is usually fully restored, although some patients may have permanent vision loss caused by retinal infection. So then there is vertebrovascular system syndromes. We see the cases of a 15-year-old boy having vomiting, tinnitus, and unsteady noise. In first diagram, you can see the T1 coronal postclonism magnetic resonance imaging (MRI) shows the enhanced lesions of the superior aspect of the left cerebral hemisphere consistent with the superior cerebral artery infarct. And in second diagram, you can see the anterior posterior view of the left vertebral artery injection shows the filling defect of the basilar apex and involving the primordial left superior cerebral artery consent and with thromboembolism you can see in the diagram. So the vertebral cerebral system syndromes, these are the areas of the cerebellum supplied by the posterior cerebral artery, PICA, are variable. There are several different patterns of the PICA, hereditary cerebral infarction. If the medical branch of the territory is affected involving vermis and vestibulocerebrum, clinical findings include prominent vertigo, ataxia, and nystagmus. The lateral cerebral hemisphere is involved. Patient can have vertigo, get ataxia, limb dysmetria, and ataxia, nausea, vomiting, conjugate or disconjugate gaze pulses, pneumosis, or dysarthria. Then, if the infection is large and altered consciousness or the confusion may occur as a result of cerebral edema causing obstruction, hydrocephalus, or brainstem compression. So diagnosis of the ischemic stroke, as we can see the flare magnetic resonance imaging of the patient, the cerebral autosomal dominant arteriopathy with the subcortical infarcts and leukoencephalography, which is called as CARDASIL. An ischemic stroke develops when there is an interrupted cerebral blood flow to the area of the brain. Ischemic strokes account for approximately 80% to 88% of the whole of the stroke. Ischemic stroke may be result from various causes may be there. First cause is large artery atherosclerosis disease resulting in stenosis or occlusion. The small vessel or the penetrating artery disease, which is called as lacunates. Cardiogenic or the artery to artery embolism. Non-atherosclerotic vasculopathies, hypercoagulate disorders, and back to the undetermined causes. The most recognized mechanistic classification is TOAST, TOAST, which is done by trial of the organization 10172 in acute stroke treatment classification. So we can see that these are all the clinical picture, how to do the diagnosis. In the third diagram, you can see the example of the patient prior to the strokes. The medial cerebral artery proximal stenosis is there with the new left-sided weakness. The second diagram, you can see T1 weight magnetic MRI with the with the contrast of the 14-year-old boy, which demonstrates the bilateral recurrent artery of the humeral territory infarcts with the involvement of the head and caudate nucleus, anterior limits to the internal capsule. And the first diagram is about the axial position of the MRI, which demonstrates the increased sign of the intensity involving the head of the left caudate nucleus and left reticular nucleus consistent with the infarction. So treatment is basically depends on the time of the onset. If the onset is known or onset is unknown. If the onset is known, we can do it. If it is within the 6 hours, we can give like we can classify it as a minor stroke or the large infarct. Then for the minor stroke, we can give IV of ELO type 7. Then for the large infarct, we can give the uh, decletion based on CTP, which is EVT. If the duration of the uh, onset known is between 16 to 24 hours. We can give the therapy like NIHSS, which is greater than 10 ml, and infarct volume less than 31 cc. For age group less than greater than 80 years, we can give NIHSS greater than 10 cc. And if the time of onset is unknown, there is tissue clock or perfusion may be there. We can use IV alteplate for the less than 6 hour algorithm, and for perfusion we can give IV altrate. So thank you.